So this session is about mastering advanced GI bleeding, more techniques for clinical excellence. The objectives of this session are to understand strategies for managing chronic small bowel bleeding with capsular endoscopy. That now comes last. Learn where to transition from endoscopy to alternative therapies in GI bleeding cases, and gain insights in the surgical options when endoscopic treatment fails. We can talk about the quiz question for this session. So I'm expecting you to get this run right, Phil. According to N.B. Muraya et al., Gastrointestinal Endoscopy 2019, what is the rate of early video capsular endoscopy that localized the bleeding source in upper GI bleeding of the acute variety? Is it 31, 45, 64, 77, or 85? Some of those are quite precise, aren't they? So it's almost certainly going to be A or C. There's a little tip, because the others are probably just made up.
So the learning objectives of my talk is when we should proceed from GI bleeding from endoscopy to alternative therapies. And I think there's just two questions really, which is when we should do that, and then which alternative therapies we have. And I think the reasons for failing endoscopy, I think, should just be clear, and you all know that. This is what you see, usually red, most of the times. And then it might be either because you're unable to visualize or localize the culprit at all. Maybe because it's not red, there's just no active bleeding. And I really like the previous talk also about mentioning whether you see any blood at all or not, because that really also guides you on whether you should try again at a later stage in the same place or think of another spot.
And let's see if we can
burn without making it bleed.
You happy, David?
Maybe a little bit more on the
I
right.
do on that right upper side?
I think
we can do that. But you want to get this sort of golden brown appearance.
Very nice so far. Nice.
All right, I'm happy with it.
Now I'm very happy.
Happy?
Now I'm very happy.
It's all about your happiness.
Yeah, in that case, I'm very happy.
Well, the characteristics of angioectasia are that they are very much the commonest diagnosis, cause of iron deficiency anemia in the small bowel in the older population with chronic comorbidities. So this study suggested chronic kidney disease, but our own studies suggested also patients with cirrhosis and heart failure. So if it's somebody over the age of 65 with comorbidities, it's likely to be angioectasia. And if they're not requiring repeated blood transfusions, perhaps it's reasonable just to give them iron as required rather than do anything about the angioectasias per se.